All right, if you're a medical trainee, insulin resistance is something you're going to see a lot. So today, we're going to break down the core science, the diagnosis, and the management, all using the latest clinical guidance. The goal here is to give you a really clear, actionable framework you can start using in your practice right away.
So, here's our game plan. First, we're diving into the science, what's actually going on inside the body. Then, we'll put on our detective hats and figure out how to spot patients who are at risk. After that, we'll get down to the nitty-gritty of making a diagnosis. And finally, the most important part, the action plan for prevention and management. Ready? Let's jump in.
Okay, to really get a handle on insulin resistance, we've got to start small. Microscopic. We need to understand what's happening at the cellular level, long before it ever shows up as a problem in the clinic. So at its heart, insulin resistance is basically a communication problem. Think of it like this. Insulin is the key, and your muscle and fat cells have locks. Normally, the key slides in, the door opens, and glucose comes inside to be used for energy. Perfect. But with insulin resistance, that lock gets rusty. The key doesn't turn so well anymore. So glucose gets left outside, stuck in the bloodstream. The body's response? The pancreas basically starts shouting, "We need more keys!" And it works like crazy to pump out tons of extra insulin to try and force those stubborn locks open.
And this doesn't happen overnight. It's a slow burn. It all kicks off with that initial resistance. And for years, sometimes decades, the pancreas just compensates and works overtime, and blood sugar looks totally normal. But eventually, those insulin-producing cells in the pancreas just get worn out. They get fatigued. They just can't keep up with the demand anymore. And that is the tipping point. That's when you have this relative lack of insulin, and blood glucose levels finally start to climb into that hyperglycemic range.
So how does this whole microscopic drama actually appear in your clinic? Well, it often shows up as something called metabolic syndrome. It's really a cluster of signs that you can measure directly. Things like a larger waistline, high triglycerides, low good HDL cholesterol, elevated blood pressure, and, of course, a fasting glucose that's starting to creep up. Now, these aren't just random findings. They are all the downstream consequences of the body's struggle with insulin. When your patient ticks off at least 3 of these 5 boxes, you are looking at the clinical face of insulin resistance.
Okay, so we've got the what down. Now let's switch gears to the who. Our job as clinicians is to be detectives. Really, it's to find the patients who are on this path, often when they have no idea anything is wrong.
And this is the million-dollar question, right? In a busy clinic, you can't screen everybody for everything. So you have to be smart. You have to be targeted. Where do we focus our energy to catch this early and make the biggest difference?
What's really interesting here is that the 2 major players in the U.S. have slightly different playbooks. You've got the American Diabetes Association, the ADA, and they say you should screen all adults starting at age 35, or any adult who has a BMI over 25 and at least one other risk factor, like a family history of diabetes. Then you have the U.S. Preventive Services Task Force, the USPSTF. They're a little more focused. They recommend screening adults from age 35 to 70 if they are overweight or have obesity. Knowing both of these guidelines is key to making the right call for your specific patient. All right, so you've used the guidelines, you've identified a patient who needs screening, and you've got their lab results back. Now what? Let's talk about how we turn those numbers into a concrete diagnosis. To make that official diagnosis, we really have 3 main tools in our toolbox, and it's absolutely critical to know the specific cutoffs for each one.
And here they are, the numbers you gotta know. For our 3 main tests, the hemoglobin A1C, the fasting plasma glucose, and the 2-hour oral glucose tolerance test, there are very clear lines in the sand for what's normal, what's prediabetes, and what officially crosses over into diabetes. Seriously, committing these ranges to memory is fundamental.
Now here is a super important clinical pearl. You never, ever make a life-changing diagnosis like this based on one slightly off lab value in a patient who feels totally fine. The guidelines are crystal clear. You need confirmation. That can mean 2 different abnormal tests from the same blood draw, like an A1C and a fasting glucose, or you just repeat the one abnormal test on a different day to make sure it wasn't a fluke.
So which test should you order? Well, there's no single right answer, because each one comes with its own pros and cons. The A1C is awesome because it's convenient, no fasting needed, but it can be less sensitive and some things, like anemia, can throw off the result. The fasting glucose is cheap and easy, but it's really just a snapshot of one moment in time. And the oral glucose tolerance test, the OGTT, It's the most sensitive for picking up early problems, but it's a huge pain for the patient, it's expensive, and it's not always reproducible. Your choice really depends on the patient sitting in front of you.
And now we get to what I think is the most exciting part. Once you've found someone with prediabetes, what do you do about it? This is where we can make a truly massive difference in someone's life. This is the action plan. This quote says it all. Progression to type 2 diabetes is not inevitable, not even close. We have incredibly powerful evidence-based tools that can put the brakes on this process, or even stop it in its tracks. And that is a message of hope and empowerment we need to give our patients. Look, if you remember one number from this entire explainer, I want it to be this one, 58%. The huge landmark study called the Diabetes Prevention Program, or DPP, proved that an intensive lifestyle program could slash the rate of developing type 2 diabetes by 58%. That is just a mind-blowing number. It's more effective than any preventative drug we have. So what does this intensive lifestyle modification actually mean in the real world? It's not as intimidating as it sounds. It really just boils down to these 3 core goals. Number 1, a modest but sustainable weight loss of about 7%. Number 2, getting active for at least 150 minutes a week. Think a brisk walk most days. And number 3, shifting the diet to focus on whole, nutrient-packed foods. These are concrete, achievable targets you can set with your patients. But let's be real. Lifestyle change is hard, and for some patients at very high risk, it might not be enough all on its own. So that brings up the next question. What does the evidence say about using medication to help prevent diabetes?
The clear winner here is metformin. That same big DPP study showed that metformin cut the risk of developing diabetes by 31%. It's safe, and it's been around forever. But, and this is a big but, we don't just put everyone with prediabetes on it. The guidelines say we should consider it for those at the highest risk. We're talking about younger and middle-aged adults with a high BMI, people whose glucose or A1C levels are on the higher end of the prediabetes range, and women who've had gestational diabetes. It's about being selective.
This chart just puts it all into perspective, doesn't it? I mean, look at that. You can see the huge impact of lifestyle changes. That 58% bar just towers over the others. Metformin is also clearly a big help at 31%. The picture tells the story. Lifestyle is always our number 1, most powerful tool, and metformin is an excellent second-line option for the right person. In the end, it all comes down to the person sitting in the exam room with you. There's no single algorithm that works for everyone. It has to be a patient-centered decision. We have to weigh all the evidence against their other health issues, their risk factors, what they can afford, and most importantly, what they want. It's a partnership. And that leaves us with one final big picture question for you to think about as you continue your careers. Today, we talked a lot about stopping prediabetes from turning into diabetes. But as the science gets better and better, will the goalposts move? Will we one day start treating insulin resistance itself way before the blood sugar even starts to budge? That is the question that's probably going to shape the future of this field and your future practice within it.